Hi guys, it's Dr. Ron Miller here with CashBasedPhysicalTherapy.org, and we're going to go over another case study today. Okay, so you may have not learned this in school, but we're going to talk about QL hypertonicity. Okay, so if you're doing an eval and you see a patient and the quadratus lumborum is hypertonic, I want to get a good discussion going of what are some causes and what are some effects of this, and then treatment interventions for that. So, and we can have a list, and I'm not arguing theories. What I want to kind of go over is this is a positive finding that we all see. Now, what are some causes of this QL hypertonicity? And then what are the results after a treatment? I want to look at within session changes. So I'll start this at first, okay? Again, we're not arguing theory. I want to look at your reasoning behind it, and then what do you do within session that you can go back and reassess, and there's less tone in the QL muscle. Okay, so one of the causes that I see in the clinic, and again, you can go back to this, you see QL hypertonicity, say it's on the left side, and the left leg is longer in supine, and you're going along with the anterior pelvic tilt kind of theory with this. Okay, so I'm doing an eval. I can touch the left QL. In supine, the left leg presents longer, and I believe that they're in an anterior pelvic tilt. Okay, so that's a reasonable theory. Now, what do I do to do that? So my treatment for this is I like to do a left HVLAT to posterior rotation of that left innominant. Okay, I get an HVLAT now. In theory, am I cracking the spine? Am I moving the SI joint? You know, that's a whole nother topic of discussion with this. But I know that when I present with this, when I see this in the clinic and I can do this treatment technique, I see a decrease in QL hypertonicity on that side, which would support this theory. Okay, so that's one example of what I see pre and post treatment that actually shows a change to QL hypertonicity. Now what I want to start is, let's get a good discussion with everyone and let's create a list. What are some other theories or causes that you see QL hypertonicity in your patients? If so, what treatment do you do here? Or what treatment technique or what intervention do you do to decrease the tone, and what's your reasoning for that? Okay, within session or within week in a matter of a few sessions. So let's get a good discussion going. Causes of QL hypertonicity. What is your reasoning behind it, or your theory of why it's there? What treatment do you do and implement, and then test, retest afterwards and see if the QL has changed, better, same, or worse. So let's get some good discussion going and kind of look at some QL hypertonicity theories and reasonings of why it's happening, and what treatments or interventions do you do to help decrease that. So just put your comments or your answers in the comment box below. We'll probably get some excellent discussions here going on, and it should help a lot of you guys out in cash-based clinics who are seeing this, who maybe you do some things and it's like it's not responding the way I want. What are some other possibilities here that could cause QL hypertonicity? So put your comment box in the comments below and let's get some discussion started. Thanks.